Welcome to today's Insta Live again. And today we have a very special guest, and we're talking about a very important topic. We're talking about endometrial preparation when undergoing fertility treatment with egg donation. So I'm going to invite Dr. Anna from ReproClinic to join us on this very special Insta Live. And it's really important to talk about this topic because we want to know what are the different ways of preparing the endometrial when you are undergoing egg donation treatment to make sure that your endometrium is ready to receive the fertilized egg, the embryo that has developed, to make sure that you are giving that embryo the best possible chances of surviving and thriving and leading to a beautiful baby. So we want to talk about it, and let me see if I can invite ReproClinic to join us. And we want to talk about all of these things, and we're going to start by talking about the egg donation process in itself, because it's different to having normal fertility treatment. We want to understand what the process looks like for women who are donating their eggs and what happens to women who are receiving their eggs. What does the process look like for everyone on one side and on the other side? And what does the process look like when you have the preparation of the endometrium happening at the same time as the woman who is donating her eggs is getting ready to donate his eggs? But also we want to understand the different side of it. What does the endometrium preparation looks like when the preparation and the egg collection is not happening in a synchronized manner? So we want to understand all the options, because what is right for you might not be right for someone else. And we want to understand what are the best options for you, whether there is a best way now that we're all facing COVID, travel restrictions. So there might be one way that is more suitable to what the reality is right now. And we're going to talk with Dr. Anna from ReproClinic. She's going to tell us all about it. I'm trying to get her to join in. Let me see if she can join us. And hopefully she'll be able to answer all our questions about this very important topic. So I understand that sometimes it can be a bit challenging to understand Instagram, and all these technical bits can be a bit more challenging. But I've sent the invite, so let's see if Dr. Anna can join us. And, if you have any questions about endometrial preparation, you can write them in the chat today. And we will be more than happy to have them answered as well. I can see Dr. Anna has joined us. Let's just bring her up to our screen, and we'll get this Insta Live started. As I mentioned, for all of you who have just joined us, we're going to talk about endometrial preparation when having fertility treatment with egg donation. So I'm sending an invite to Dr. Anna at ReproClinic to see if she can join us on the screen and help us answer all the questions we have about this topic. We want to understand what is egg donation. When should we consider egg donation as a solution?
Oh, hello. Hi, hello.
How are you?
Hi, Andrea. Sorry for the delay. I don't know what happened. Probably I'm not very used to Instagram lives and all these things. I'm sorry for that. I was here from 20 minutes before the time, and I was like waiting. But sorry for that to you and to all the participants.
That's okay. What matters is that we are here now, and about such an important endometrial patient when under fertility treatment. And I would like to start start in the beginning, and what is and when should we consider egg to parenthood?
Okay, so let's start a little bit from the beginning. I think I hear you a little bit your voice is stopping all the time. I don't know if there's a kind of problem with the connection, but I understood that you asked me for the very beginning of everything, which is what is egg donation, right?
Yes,
Okay.
absolutely.
Okay, fantastic. So actually, about egg donation, it's a process in which a woman will give her eggs to another woman, okay, to help that woman or that couple to have a family, to have a child. It is done in Spain. It's very important to know that here in Spain, it's totally anonymous, okay? So the only things that the recipients, the patients that are going to do this kind of treatments, the only things that they will know are going to be age, blood group, and general physical characteristics. And this process is done by women that are between 18 and 35 years old. Normally they have less than 30, okay? But by law, it should be in between those ranges of age. And those women donate their eggs to help other women, okay, to have this family plan that to help that patients and that couples.
Yeah, so they make that choice to help other women, and they have their eggs donated to help women who are struggling, who maybe don't have enough eggs, or maybe their eggs are of not very good quality to have a normal IVF treatment with their own eggs.
Exactly. So actually, what are the indications of doing
Yes.
this kind of treatments, right? There are different kind of patients that in which we will recommend to do that kind of treatments. On one hand, we have patients that don't have menses anymore because they are on menopause or premature ovarian failure or menopause due to chemotherapy or surgeries, things like that, okay? Or just menopausal women because of age. This is the part in which it's very easy to decide because we don't have eggs. So that's the only option that we have in those cases. And then we have the other part of the cases in which we have women with menses. And I have to say that the most important reason why someone should or will need this kind of treatments is age. All this is related with age because fertility goes very related with the age of the female more than the male part. So it's very important to know all this information, to know that we women are born with a specific ovarian reserve that decreases with age in terms of numbers, but also in terms of quality of the eggs that we will have. And we have tests to see how is the quantity, so how is the ovarian reserve, the total amount of eggs that we still have, but we don't have tests to see how the quality of these eggs is, okay? What we do know is that after 37, 35, 37, the quality starts to decrease and the quantity decreases more rapidly. And after 40, it's more tricky to become pregnant. So it's you have a higher risk of having a miscarriage when you become pregnant. You have a higher risk of having troubles to become pregnant, or of having problems with the baby that will born, like chromosomical problems. And I always explain that the reason for that is the quality of the eggs, because you have to think about that the egg has all the genetic information that we have in our body, okay? But to create an embryo, we need to split that information into two, because half of the information will come from the egg, and the other half of the information will come from the sperm. And here is where we can have some troubles with age and due to the quality, because all this material that needs to be splitted while all this maturation of the follicle of the oocyte occurs, this process is not well done, and then we don't have the normal chromosomal numbers in the oocyte. It can be that one egg has one more chromosome than it should be, the other one less, and this can lead to abnormal embryos, okay? And all this goes related with the quality, that goes related with age. And actually, it's what I told you. Most of the patients that need to go for an egg donation are in this part of the patients, because nowadays socially everything is changing, and because of work, because of we have partners later, we want to have children later, and this is something that can give us some troubles when we want to conceive. And sorry, I was just the little part, because in this specific part of patients that still have menses, we also have other kind of patients that will need this kind of treatments, like patients that, for example, have done a lot of IVF treatments before, and that have a lot of failures, and that want to go on and have a better chance of having a baby, or patients that, for example, can have a genetical problem that the baby could inherit it, or other. It's very personalized. I always have to talk in general terms, but it's true that every patient is different. It will never be the same one patient with 40 years and with low ovarian reserve than another with 43 and high ovarian reserve. So we need to see what every patient has of history of previous treatments and everything, and then to see in which patient this will be the best option.
Yeah, I often find that couples struggle a bit with accepting egg donation as a route to parenthood. But I think it's important that we are talking about it. And like you said, there's lots of people, lots of different situations in which this can give them the baby they want. And I would even say that for those people who have tried before with IVF and who are older, maybe having a younger egg will increase their chances of being successful with treatment, isn't it?
Yes, for sure. Yeah. It is the treatment that is going to give the best option in this kind of patients in which we have seen that it has not worked, or because of age. So yes, this is, and it's normal that it's difficult to do that step. It's a big step. We understand it. It's absolutely normal. Some people need to take time and to speak to some coaches, to some people, to try to manage all these feelings. But then after, once you do the big step and they proceed, and after they have their baby, they're super happy. So I think that's the most important thing.
Yes, I think it's just a process of becoming familiar with the idea of it. And it's just because lots of family, friends, people we know, and even in society, those personalities, VIPs who have children much later in life, who clearly has to be with egg donation, but no one comes forward to say that it has been egg donation. So I think that makes it much harder for everyone. But when we process it and understand it, it becomes much easier to accept.
Absolutely, yes.
And tell me a bit about the preparation of the uterus to receive that egg that has been donated. What are the different options that women have, and what does the process in itself entail?
Okay, so first of all, to say a little bit about the process when we start, for sure it's very important to do different tests that we will ask to see if the general health is correct, to see some scans of the uterus to see that everything is correct to become pregnant, that we can not do something to increase the chances if we see a little polyp or a fibroid that should be removed. All these things need to be taken care of before starting the process. And for sure, we need to do all the tests, semen analysis to see that everything is correct, that we don't need to do anything else. And from that moment, the process starts when we have all these things done, for sure. Here in the clinic, we will do everything that it's required to make sure that the donor is correct, and that can be a donor for sure. Karyotype, psychological test, all these infectious diseases, everything, okay? To see that everything is correct, personal history, family history. Once we know that these donors can be donors, we will choose each donor for each patient regarding the physical characteristics. So normally we ask for all the general characteristics, like color of the hair, texture of the hair, of the skin, of the eyes, everything. And we ask also to send us a picture, because we will work with all these things to try to find the best donor for each patient. And another thing that could be done, that is an extra thing, is the genetic matching, which is actually something that is optional. This is because some patients can be carriers of some genetic diseases. And for example, if the male partner is carrier of some genetic disease and the egg donor is carrying the same genetic disease, we could have a baby affected of that disease in a 25% of probability. So there's something that's called the genetic matching, that is testing the genetics of the male part, okay, and then testing the genetics of the donor to make sure that they match correctly and that they are not carrying the same diseases, okay? But this is optional because the general risk of having that is not very high. It's quite low.
Okay.
Right? It's an option. So once we have done all the tests, we have decided which patient with which recipient, what we normally do is we stimulate the donor. The stimulation normally is 9 or 10 days. We take the eggs, and that day we will need the sperm sample. There are different ways of doing it. Normally here, what we do is, before starting all this process, the male partner can come just for 1 day here and can leave a sperm sample, if the sperm sample is correct, that we will freeze and that we will use after, okay, to make a little bit easier all the process. In a second time, we stimulate the donor, we take the eggs, we fertilize those eggs with the sperm sample that we have here, and then we wait for 5 or 6 days until we have the stage of blastocyst. That is the best stage of embryo in which we will put the embryo back, we will do the embryo transfer. And what we normally do, more with patients that are abroad, is freeze those embryos, okay? So that we, in a second time, we can prepare our recipients, our patients. We can do all this in the endometrial preparation, that I will explain you how it works also. But we normally do it like that, but also we can do it synchronized with the donor. Okay, that means that the recipient will start a little bit before that the donor starts. She will start the endometrial preparation with estrogen patches or tablets. And then once we see that she's ready, she will be waiting for the donor, for the egg donor, okay? The bad part of doing it synchronized is that the patients will know more or less when the dates of the egg retrieval will be, but not exactly until 2 or 3 days before. One little problem, okay? The other thing is that once we know it, they should come here, and normally they come together, and they should be here for 8 days, because they need to be here the day before the egg retrieval to make sure that the partner is here to give the sperm sample. Yeah, exactly. And then wait 5 or 6 days until we do the embryo transfer, and then go back. Okay. The problem is, for example, if something happens and we don't have enough eggs, or we don't have fertilization of the eggs, or we don't have blastocysts to transfer, that is quite rare, but could happen. If we have done everything synchronized, these patients have started the preparation, they have come here, they have traveled, take the hotel, plane, they are here for almost 1 week or more, and then nothing to transfer. So that's why we normally do it with frozen embryos, because of that, to avoid a little bit that stress of last minute, and because also we have pretty much the same success rates per embryo transferred, okay? So actually that makes it much easier for patients that are abroad. Saying that, this is like the first part. Yeah. And now comes the part of the endometrial preparation, okay? How does this work? So if we do it like that, we do with a frozen embryo transfer, what we will do is prepare the endometrium lining to receive that embryo that has been created, okay? And to do that, there are 2 options. We have, on one hand, the natural cycle, which normally is natural modified, that I will explain you, or the medicated cycles. Okay. First of all, to explain the natural cycle, you should know that what happens in a normal cycle of conception is that we have different eggs available to grow, to mature in our ovaries at the beginning of our cycle. But we have hormones to make one follicle grow, and we will ovulate one egg, okay? And then what happens is that this follicle that grows creates estrogens, and these estrogens prepare the endometrium lining, make this endometrial lining grow. After, when we have the ovulation, this egg will be released, okay? And what happens is that the scar that is left in the ovary, that is the corpus luteum, is going to produce the estrogens and progesterone. So from the moment of the ovulation, the endometrium will receive that influence of the progesterone and will make like a maturation of the endometrium to let the embryo implant. Okay, so we have like these two parts of the cycle. First, estrogens, and when everything is correct, then start the progesterone levels that will make mature this endometrium. What happens with a natural cycle for an endometrial preparation for a cryotransfer? So what we do is we follow the follicle that grows naturally. Once we see that more or less the endometrium lining measures correctly, the follicle is correct, and the hormone levels are correct, what we do is we trigger the ovulation with an injection, with a medication, okay? And this is why it's called natural modified cycle, okay? And this makes it much easier to control exactly when the patient is ovulating, and it is much accurate to program exactly when we need to do the embryo transfer. So in a natural cycle, actually what we are doing is we are using the hormones that are created by your body, by the ovaries, and it's like making your body think that the embryo that we are putting comes from that egg that was released, okay? Yeah. It's like making everything a little bit more natural process, okay? This is natural modified cycle. And on the other hand, we have the medicated cycle, which is actually a start of estrogens at the beginning of the menstruation. So this influence of the estrogens, we will give these estrogens to make this endometrium lining grow, okay? We will do some days later, 10 days, 12 days later, we will do a first scan and a blood test. And if everything is correct, we can start to program the embryo transfer from 5 days later, or 10 or 15 days later. So with a medicated cycle, what we do is we suppress with these estrogens the ovarian function, and we do this function of the growth of the endometrium externally with giving some hormones, some estrogen, okay? This has some pros and cons, these two cycles. On one hand, the medicated cycle has more flexibility because we control the cycle. We don't have to rush and here or there. We have less probability of canceling the cycle, for example, also. And it's the cycle that we can do when we have menopausal women. We have no other option, or very irregular cycles, very, very short cycles. In these kind of cycles, it's better to do everything medicated. And with patients that live abroad, normally it's what is done because it's much easier for the patients. And on the other hand, the natural cycle has one good thing, that you don't need to take that much medication, because actually in a natural cycle, the bad part is that you don't have flexibility, because your ovary is the boss. Your body is going to tell us when, not we, okay? But you will not need to take that much medication for so long time, because with a medicated cycle, we will need to take medication for 8-10 weeks of pregnancy until the placenta takes over and creates all these hormones. Okay, so these are like the pros and cons.
And when we are doing treatment with donor eggs, if we are stimulating a woman to collect her eggs, how many eggs are hours. So let's say if I want to go to Spain and someone has been selected as my donor and she gets like 10 eggs, of which 8 fertilize and 6 get to day 5, are all of those mine? Can I freeze them for later?
For sure. So actually, the first thing is that it will depend on the program that you choose. We have different programs, so you can choose 4 mature eggs, 6, 8, which is the standard one, 8 mature eggs. And when we have a normal semen analysis, normally with a standard program of 8 mature eggs, we will have at least 2 blastocysts, okay? And we have other programs like 10 mature eggs or 15 mature eggs. So it will depend a little bit on what the patients choose, okay? But the thing is that after when we fertilize those eggs, like you said, like 10 eggs for me, all of them fertilized, and you have 6 embryos, fantastic for you. All these embryos are yours, okay? And actually by law, the Spanish laws says that we need to freeze those eggs. We cannot leave them. So if, for example, someone told us, no, I just want to put 1 embryo and not freeze the rest, which is a bad idea. But still, if someone said that, it is not possible because we cannot just throw them away. We have to keep them and actually it's a bad idea because we never know if the patient will become pregnant with the first attempt, the second attempt, or for example, if she will need to use more embryos for a second child, for example. So we always recommend I mean, it's something that we need to do, but it's a good thing. It's a good idea, actually.
And I was looking at your website today because I had a patient asking for clinics who do egg donation programs. And I could see that you have special programs for patients from abroad. And it might be because it can be a bit challenging for everyone to travel at the moment. Can you tell us a bit about these programs and how you're going around the travel problem at the moment?
Yes, it's normal. I think when you do a treatment, a fertility treatment, it's always stressful, but even more if you do it abroad, more because you don't know exactly where you're going, or maybe you don't know the city and you don't know the place. So it's always a good idea also to come here for a visit and to meet each other if they want, to see the clinic, to leave the sperm sample at the same time. So normally it's what our patients do. They come for 1 day, they leave the sperm sample. They can come together also so that they can see the clinic, everything. And then after, I mean, we have a lot of patients that are from abroad and all of them are doing the treatments. It's true that some months ago we had some problems with patients from UK because you had a lot of problems to travel for the travel restrictions, but still we have had patients from all over the world and also from UK now we're having. We try to help you in the best way. Of course, all the things are changing week to week, I would say, and now you will need a PCR of COVID and after maybe not, or in all these little aspects we will try to help the patients, because some patients ask us, do I need that kind of test to travel? Well, now you need it, but maybe in 2 months we don't know.
You won't, yeah.
So that's a little bit, and we try to help patients with all this process of trying to help them to organize a little bit, to come for the test or to leave the sperm sample, to organize the treatment. For sure, when they're inside the treatment, we will send a letter sending that this patient needs a medical treatment to help to travel so that they don't have problems to take the plane and all these things. So in this sense, we try to help our patients to do all this process as much as we can.
And so the big message is that it is possible at the moment to travel to Spain and to ReproClinic to have treatment. And I understand that probably the first step would even be to get in touch for an online consultation, because that would help you plan all these steps that you're talking about as well.
Exactly. The first thing is the first visit that we do. In that visit, I tell patients about the test, everything that they need to have. We send a mail with, of course, the cost and all these things that are also important for the patients. And then with the second visit of with all the results that they have, we start to program all the process and to organize it. And our idea is that each patient has like a team, okay, that for example it's me or another doctor, okay, but if this patient has me like a gynecologist, I will be always following that patient. And this one will have a medical assistant and a patient assistant as well, that will help in more medical aspects and in administrative aspects. So we try to do it a little bit like a team.
Yes.
In that sense. Mm-hmm.
And Dr. Anna, one last advice for everyone who is watching, who is considering maybe egg donation is my next step. What should they do? One last piece of advice.
One last piece of advice. I think the first thing is consider it. Once you start to consider it, it's a big step, but it's a good step in many cases, for sure. All the patients needs to be taken, in consideration, and each patient is different. But doing this big step, it's a big thing, and normally also some patients will need a little bit of help to do that step. But after, as I told you, once everything has been done, and the patient have their baby, all these aspects are back, and everything is good, and they're very happy. So I think the first step is looking at each patient carefully, seeing what is good for every patient, and then do a visit and try to talk with someone a little bit to understand how the process is, and also if it's needed, which is also a very good idea, to talk with a coach or psychologist. Someone can help them to not only do that step, but to go with that step good, comfortably, and be have that peace of mind.
Dr. Anna, thank you so much for clarifying all these questions and explaining to us what the egg donation process is and what the different stimulation and preparation of the endometrium options are, and what are the pros and cons of each option. I think it will really help a lot of people. But of course, if anyone has questions, just reach out to us, send us a message, or send a message to ReproClinic. I'm sure we will all be able to help you, and we'll be able to answer all your questions.
Exactly.
Thank you so much, Dr. Anna.
Thank you very much for inviting me. A pleasure.
Bye.
Bye.